everyone. I'd like to welcome you to the ALD Connect 2020 Patient Learning Academy session on genetic counseling for ALD. My name is Felicity Emerson. I'm a volunteer at ALD Connect, and it's my pleasure to introduce our two panelists today. First, we have Deirdre Sumski, who's a prenatal genetic counselor at Crystal Run Healthcare in New York, who will tell us about the genetic basis and inheritance of ALD and genetic options. And secondly, we have Janis Sherwood, an ALD patient who's been very active in the ALD community for many years and has generously offered to share her patient perspective on genetic counseling in ALD and to discuss her genetic family tree with Deirdre. So with that, I'll turn it over to Deirdre.
Hey, hi everyone. Let me share my presentation with you. Okay. So my name is Deirdre. As Felicity said, I'm a genetic counselor and I do specialize in prenatal, but I'm happy to come talk to you today about the genetics of ALD. So I'm sure a lot of you are aware that this is a genetic condition caused by a mutation in a particular gene known as the ABCD1 gene. Normally, this functions to produce a protein that helps the body process a type of fatty acid, okay? This is known as a very long-chain fatty acid. When somebody has a mutation in the gene, it causes the instruction for the protein not to be read properly, and then when the protein doesn't work, these fatty acids are not processed appropriately, and they can accumulate in the body, becoming toxic, okay? So this gene is located on the X chromosome, all right? And something unique about this condition is that it does have an X-linked inheritance, okay? So we all have 46 chromosomes. Women have 2 X chromosomes. These are known as the sex chromosomes, and men have an X and a Y, okay? This is often the reason as to why women are known as carriers. They could have some mild to moderate symptoms, whereas males are generally affected and at risk for a more severe presentation of the condition. Generally speaking, this condition is inherited from a parent, but there have been a few cases where it's caused by a de novo mutation in the gene, meaning a mutation that occurs sporadically or randomly at the moment of conception for that child, okay? So here I have a visual aid helping us kind of process and understand X-linked recessive inheritance. On the left, I have an unaffected father and a carrier mother, okay? So because women have 2 X chromosomes, they have 1 X chromosome if they're a carrier with the mutated gene, and 1 that does not have the mutated gene or the condition, okay? So women who are carriers have a 50% chance to have a son with the condition and without the condition, okay? For their daughters, they also have a 50% chance to pass on that X chromosome with the copy of the mutated gene versus not, okay? So generally speaking, for each child, it's a 50% chance that they're gonna pass on the condition, and we know that males are more likely to be affected, okay? For an affected father with the condition, they are not at risk to have a son with the condition, okay? That's because fathers give their sons the Y chromosome, not an X chromosome. However, the flip side to that is all of their daughters are obligate carriers of the condition, meaning that fathers only have 1 X chromosome, so if they have the condition, they're only able to pass down that X chromosome with the condition. So there is this common misconception that women are unaffected carriers. We do know that women are often affected and they can be quite severely affected, and clearly more research on the topic is needed. One genetic process that I wanted to inform you guys of is something called lionization, or otherwise known as X inactivation. Because women have 2 copies of the X chromosome in their cell, every cell in the body randomly turns off 1 copy of the X chromosome, okay? Generally speaking, in our cells, 50% of our cells would have the copy from, let's say, our mothers on and working, and the other 50% would have the copy from our fathers on and working, with the other one being silent, okay? Because of this, we know that, women have 1 good copy of a chromosome to kind of compensate for the fact that they might carry the condition. And generally speaking, that's why they have little to mild symptoms. However, we do know that some women are quite profoundly affected by ALD, and that may be due to something called skewed X inactivation. This would mean that instead of kind of a general 50-50 of the cells having one copy of the chromosome versus the other, maybe the chromosome X with the mutation and with the condition is actually being expressed in the majority of that person's cells rather than 50%. It could be 80-30, a type of ratio like that. And that could be a contributing factor as to why women have a varying spectrum of the condition in terms of presentation. So I do have a little diagram over here. You can see X chromosome for mom and dad. I have an adult tortoiseshell cat, and this is an actual real life example of this X inactivation. So you can see some of the chromosomes with the orange pigment are being expressed, whereas others with the black pigment are being expressed. So that's kind of how X inactivation would present. Okay. So we're aware that, generally speaking, while this is considered one condition, ALD, there are different forms of the condition. The one that we'd be most concerned about is the cerebral childhood onset form that affects males. Okay, this is a very devastating condition that needs immediate attention once diagnosed, and approximately 20 to 30% of boys with ALD are at risk for this cerebral form. There's also the adrenomyeloneuropathy form, which some studies say there's close to 100% penetrance, meaning that women and males with this condition will have some symptom, whether it's severe to mild form of this AMN condition. Another form of the condition or symptom of it is Addison's disease. This is also known as adrenal insufficiency. This can be very, very serious, and it needs to be addressed if the case. Approximately 90% of men will have this adrenal insufficiency that needs to be treated, and 10% this may be their only symptom. So this is a very important condition that men need to be regularly monitored for. Currently, we do know that there's a variety of mutations in the ABCD1 gene that cause ALD. A lot of these mutations are unique to individual families. However, there's no clear genotype to phenotype correlation. And what that means is, based on the type of mutation in the gene, we're not effectively able to predict the presentation of the condition or how severe it's going to be. For some conditions, aside from ALD, we're able to tell based on the mutation how somebody might, show symptoms. So if it's a very serious mutation that completely deletes the whole gene, we know that they're going to have a severe presentation. But in this condition, there's no clear association. So we're not really able to predict a person's presentation based off genetic testing. We also know that there's variable expression of the condition within a single family that carries the same mutation. So we'll see individuals in one family who have very mild to no symptoms and very severe symptoms, even though they carry the same genetic change. There's even studies that show identical twins presenting differently as well, thus likely indicating other factors aside from genetics that will, influence how this condition is going to present, possibly environmental, epigenetic. It's not clearly understood at this point. So newborn screening is a very important tool in order to identify children with the ALD condition. Newborn screening's been around for a long time, but more recently it's been screening ALD, which has been a huge step in forward in terms of studying the disease, understanding it, and working on treatments. So generally speaking, we look with newborn screening, it's usually a heel prick, and we get a little bit of dried blood spot from a newborn baby. And we're able to screen for those very long chain fatty acids that we know will be elevated in individuals with the ALD. We know that males will be detected by this. 85% of female carriers will be identified through newborn screening, but approximately 15% of these female carriers with the condition will have normal, very long chain fatty acid levels and not be detected. Here I've kind of outlined some of the biochemical findings that they use in order to screen for ALD. Something that's really important to keep in mind is that newborn screening is limited in that it's only screening. Therefore, any child that's picked up would need confirmatory genetic testing, as there's a few other conditions where we might see very long chain fatty acids increase, such as Zellweger's condition. The most important take-home message from this is that newborn screening allows affected children the opportunity to access life-saving treatment. And while it may be traumatic for the parents who get this news, it's really offering them an opportunity to prepare and take care of their child. The most severe form, which we've already talked about a little bit, is the cerebral onset form of ALD. Boys are the ones who are at risk to develop this condition. And we know that approximately 20 to 30% of boys will go on to have the cerebral form. It often presents around the ages of 5 to 12, and initial symptoms can include ADHD, memory loss, abnormal behavior. It often results in a very frustrating diagnostic odyssey of delaying appropriate diagnosis and therefore treatment. Now with newborn screening, that's helping because we're picking up children before they have these kind of symptoms, before it's too late for treatment. These boys are also at risk for the adrenal crisis, which needs to be monitored. And here I just have an MRI scan of the white matter changes that you see in children with the cerebral form. Okay. So I've highlighted a few different important steps to take in terms of monitoring and treating the condition. The MRI is very important for detecting the cerebral form of the ALD. Usually it'll happen at least annually starting ages 1 to 2, and then by ages 3 to 12, when we know boys are prone to develop the condition, it would be every 6 months. Once a lesion is detected, it's very important to start treatment before the onset of symptoms. Some treatments involve stem cell transplantation, bone marrow transplant. These can help save a life. Currently, there's a gene therapy in pipelines by Bluebird Bio. It's in clinical trials, phase 2. Instead of using a donor stem cell transplantation, it's actually using the patient's own cells. It's modifying those cells to incorporate a working copy of the ABDC gene and therefore reintroducing them into the patient's body. And hopefully those normal cells would proliferate in a person's body, therefore, halting the progression of the disease. It's also very important for a child to be monitored by endocrinology. There is a significant risk for adrenal crisis, which is very serious. It can lead to a medically induced coma and other very serious symptoms, and it's very easily treated. Monitoring starts about every 3 to 4 months for the first few years of life, and then approximately every 6 months after that. But it will be a lifetime screen for men and boys. And again, it's very easily treated. So I did want to talk to you guys about family planning options and different genetic testing options that we have, as I am a prenatal genetic counselor. One thing that I will say is it's very important to do cascade screening. And what that means is when an individual with ALD is identified in a family, it's very important we identify the familial mutation and we test other family members, both men and women, for the condition. One thing that I did want to mention is that regardless of family history, I do often offer patients something called expanded carrier screening. If you've never heard of it before, this is a blood test that can screen individuals or couples for several hundred different genetic conditions, some of which are recessive in inheritance, meaning that 2 parents need to carry them, and others are X-linked. So they can, be conditions associated with autism, metabolic conditions such as ALD. And one thing to mention is that currently there are carrier screening tests that do include ALD on their panel. So somebody who maybe doesn't realize it's running in their family could get picked up this way. So it's something I want to put out there, make you guys aware of for family planning. Another option that couples have is IVF with genetic testing. IVF would involve combining the sperm and the egg in a laboratory setting. And once an embryo is created, it's actually possible to do genetic testing on the embryo to select embryos that do not carry the condition. So I have here pre-implantation genetic testing for monogenic disorder. That's what PGT stands for. It does cost, it can be expensive, but oftentimes, insurance may or may not cover it, especially if there's a medical need. And it is an option to couples who feel that, they would want to do everything they can to make sure their child does not have the condition. One thing to mention about that is they often need samples from different generations in a family. So it's just something to keep in mind when doing IVF with genetic testing. Another somewhat new screening test that we have is something called cell-free DNA. This is a blood test that's done on mom. There's no risk to the pregnancy, and it's actually used to screen for different chromosomal disorders, such as Down syndrome. However, it does actually look at baby sex chromosomes, and therefore it is one way we can identify the fetal sex of the baby early on in gestation. So the reason why I bring that up is because we do know that boys are, more susceptible to developing that very serious cerebral child onset form of the condition. So if we do this cell-free DNA blood test, it's non-invasive, no risk to the pregnancy. If you find out it's a baby girl, you may be less likely to pursue diagnostic testing. The other options that we have during pregnancy are prenatal diagnostic testing, which would be something like an amniocentesis. This would be a procedure where we get a little bit of amniotic fluid. In the fluid are baby's skin cells, and we're able to test baby directly for that mutation in the ABCD1 gene and say definitively whether or not baby has the condition. Okay. In addition to testing for the condition, HLA typing can also be done on a potential sibling for maybe another affected child, and letting you know prenatally if this sibling is a potential match for their affected sibling. The other thing that I wanted to mention is it's very important to consider cord blood banking. So cord blood is very rich in stem cells, and if you are expecting a child, the cord blood from that pregnancy could be very useful in stem cell therapy for another affected sibling. There is a company called LifeBank USA. They actually have a Families in Need program where if there is a known genetic condition affecting a sibling, they will collect and store a sample for 5 years without charge. So that's another thing I encourage parents to look into. The last thing I wanted to mention is if you have a family history of this condition, I do encourage you to reach out to a genetic counselor. I have a link here where you can find one in your area, whether it's a prenatal counselor or if you have a child, there's pediatric counselors. So it's something to look into. Okay. And with that being said, I now have a little example of a real life family where ALD is, affected several members, and I think Janis is going to come on now and talk about her family a little bit and share her patient perspective.
Hello, excuse me. Hello, everybody. Thank you for sitting in on our session, and thank you, ALD Connect, for inviting me. My story is pretty similar to a lot of families out there. Unfortunately, before we had newborn screening, I had an 8-year-old son who had a pretty normal childhood, started having some symptoms when he was 7.5, early 8-year-old, and they were written off as normal childhood illnesses. He was diagnosed with recurring viral infections. They were evaluating him at school for attention deficit disorder. And then he was diagnosed with childhood onset migraines, which at that time I asked for a CAT scan to make sure that there wasn't one thing that was causing all these different symptoms, but I was denied and told that ADD did not cause migraines and that there was no neurological reason to that would warrant the expense of the CAT scan. So we took him home thinking that we now had things under control. Everything seemed to be pointing to these migraines. But unfortunately, 3 weeks later, he had another one, which led to an adrenal crisis. That landed him in the Children's Hospital, where after 12 days, we did get the diagnosis of ALD. And he unfortunately only survived for 6 months after that diagnosis. After I started learning more about the adult onset, well, let me back up a little bit. I obviously was screened right away, as was my daughter. She was 10 at the time. We both screened positive. Then we screened my mom, and she also screened positive. And then we looked at my grandmother, who was deceased already, but she had been diagnosed with degenerative disc disease. So it seemed to make sense that she was the one that passed it down to us. And then when I started thinking about my mom's brother, who had also passed away, we looked up what his diagnosis was. I knew it was debilitating arthritis. What I didn't know was that they had also tacked on an unknown brain disease. So he most likely developed the adult cerebral form when he was 50, and he passed away when he was 55. Looking back even further, we realized that my grandmother's sister had a little boy who died from complications of the flu. So we're pretty sure that that was because of the adrenal insufficiency. And now realize that, you know, we can go back, you know, at least 3 generations in my family. So getting genetic counseling is really important once you do have the diagnosis, and I urge everybody to do that, and especially if you have other siblings, that they get screened as well. My sister has a boy, so he was screened right away, and he was negative. And my sister declined to have the test for herself. I have a younger brother who has a daughter, so he got screened right away, and he screened negative for it, so he knew that he did not need to screen his daughter for it. I did have an older brother who unfortunately passed away in an accident about 30 years ago, but we believe he had most likely had the adrenal insufficiency, because he always had a beautiful tan. And whenever he got sick, really sick, and it took him longer to get better than anybody else. So that's pretty much how my family tree worked out. And we're hoping that, we're not hoping, we know that this gene will stop in our family with me and my daughter and my son. Was there something else that you wanted me to add, Deirdre?
No, thank you, Janis, for sharing. I really appreciate it, and you being willing for me to share your family tree on this platform. A few things I wanted to note is, in terms of genetic counseling, when you're thinking about a possible diagnosis of ALD in a family, we're looking for maybe sudden deaths of male children in the family. So you talked about those kind of extended family members of the cousins passing away from illnesses like the flu. It's very likely it could have been ALD. We think about the adrenal insufficiency, so the bronzing that you mentioned in your brother. We think about the neuropathy. So you mentioned your grandma with the degenerative disc disease. So sometimes we kind of have to be our own, detectives and put all these pieces together and realize that they're linked. But thank you for sharing.
Thank you.
I think that's all for today, Felicity.
Okay, great. I think we have 2 questions right now. We're running short on time, but I think we can take 1 or 2 questions very quickly before the next session starts at 1:45. So we have 1 question from Gina. Her son was diagnosed. Gina didn't have very long chain fatty acid or DNA markers, and took several more DNA tests with different skin samples to diagnose her as a carrier at that point. And then she has 1 adult daughter who tested positive for very long chain fatty acids. And now Gina is concerned about her 23-year-old daughter, who seems to have many possible carrier symptoms, but was negative for very long chain fatty acids and DNA at age of 9. So Gina is worried her daughter could be like her, and we may need to delve deeper. And she wants to see a genetic counselor to discuss this. And she's wondering if you work virtually and if you're able to accept patients virtually. They live in California.
Sure. Hi, Gina. That's a great question. It sounds like you guys are in a unique situation where maybe the disease-causing mutation is not present in all of your cells, so it wasn't picked up on a blood test. But as you mentioned, when they looked at other cell types, so skin sample, things like that, they did eventually detect it. Unfortunately, when a family presents like that, where you've kind of got different cell lines that are normal and other cell lines that are not, it can be very hard to pick that up. I would agree that I would also be a little bit concerned for your daughter and her risk. In regards to testing for her, I'm not sure if I could facilitate that as a prenatal genetic counselor. I would think because of your unique situation, she probably needs to see a medical geneticist who can kind of delve deeper and do the skin biopsy maybe for her. So I'm more than happy to maybe connect with you after the session today and help facilitate that.
Thank you, Deirdre. Gina's also commented on the chat, correct what you said, only 1/10 of her cells. So just like you were discussing, and I can connect the two of you after this webinar. And then I think I'll just go with one more question since we're running low on time. Rebecca asks, how possible is it that a woman who has a diet high in very long chain fatty acids can cause a newborn to have high very long chain fatty acids in his blood work, even if he doesn't have a peroxisomal disease? So would there be a hit on newborn screening that could be due to other reasons than a genetic mutation?
I wish I could answer that question with 100% certainty. I'm not sure, but what I would say with the newborn screening is that it is only screening, right? So it's not diagnostic. It's a great tool to kind of identify individuals who are at risk. So I think it's just important to recognize there's, people may come back, increased risk on a newborn screen that don't actually have the condition once further testing and analysis is done. But I can always look into your question and see if I can answer that another time.
Can I add something?
Mm-hmm.
Our bodies make 96% of our long chain fatty acids. So I don't think a diet high in fatty acids, it would affect an outcome of a test.
Thank you, Janis.
I would agree with Janis as well.
Yeah, and then, sorry, I'll just ask one more question very quickly because I think this is also important. Catherine says, 2 years ago, we found out her sister's son was diagnosed through newborn screening. She has 2 daughters that are now 10 and 12, and the genetic counselor they talked to in Gainesville at the University of Florida said they could not test them until they were 18. And she's wondering if that's common.
That is common, yeah. It's not just kind of unique to ALD. For other conditions like the BRCA genes, the breast cancer genes, it's kind of a common guideline not to test children who are not at risk to kind of manifest the condition, or at least seriously, until they're 18, to get their consent for the testing. So, yeah.
Okay, thank you so much, Deirdre and Janis, for sharing your story, Janis, and for presenting today, Deirdre. Thank you so much. We really appreciate it. And with that, I'll direct everyone to the next panel, which is starting right now. So thank you and enjoy the rest of the sessions today.